Hello, my name's Banun, and today I'll be presenting my case study 6. So just to give a brief introduction, so a 68 years old male patient comes into the clinic complaining of an itchy rash that he has on both his thigh and upper arms that started several weeks ago. We will go through the breakdown of the case study in the next few slides. So here are my differential diagnosis trees. So the differential diagnosis that I've chosen is lichen planus, allergic contact dermatitis, vasculitis, cellulitis, and psoriasis. And the provisional diagnosis that I've chosen is venous eczema. The first differential diagnosis is lichen planus. The ruling in for this one is that erythematous skin with plaques, which can cause that pruritus, itchiness. It can also affect both upper and lower limbs. Patient also said that they recently had this skin problem. It could be due to external factors such as environmental, which is aligned with lichen planus risk factors. Ruling out for this one is they have a lot more scaly plaques, a circular cluster of papules, which have irregular white streaks, which can be shown on this photo here, and have undefined border. It is more generalized than localized, as it attacks inflammatory and mucous membrane. The diagnostic test for this one is analyze if there's any lacy patches of tiny dots on the mouth. Blood tests such as hepatitis C, which is highly related to lichen planus, and biopsy tests will be needed to confirm ruling. The second one is allergic contact dermatitis. The ruling in for this one is that erythematous skin with cluster of papules, which can cause that pruritus. Leathery patches that are darker than usual, hyperpigmentation, typically brown or purple. Ruling out for this one is it normally has that vesicles and blister on that erythematous base. And sometimes it has that oozing fluid or pus trapped in and crusting. It can be painful with burning or stinging sensation. Diagnostic test for this one is patch test to detect any delayed allergic reactions and biopsy to confirm ruling out for this condition. The next one is vasculitis. Ruling in for this one is erythematous base with purple hemorrhage under the skin. It could be small or large. It can affect any blood vessels in the body, including in arms and legs, as well as swelling surround the localized area. Ruling out for this one is it is more generalized than localized condition, with symmetrical distribution of the lesion. It can cause fever, fatigue, weight loss, and sweat, which are questioned because the patient did not report any signs. Diagnostic tests is blood tests. Look for certain antibodies, such as the anti-neutrophil cytoplasmic antibody, that can help diagnose vasculitis, as well as biopsy to confirm ruling out. The next one is cellulitis. Ruling in for this one is erythematous area with swollen, dry, and flaky skin. It affects lower legs. Continue that breakdown of the epidermis skin, possibly due to excoriation and scratching, which may be it has that itchiness. Ruling out for this one is tenderness to palpation, tight and glossy stretch appeared of the skin. Skin look pitted, may have blister with underlying fluid or pus. Signs of infection is present, such as fever, pain, skin redness that gets bigger and bigger, which is still questioned because the patient did not mention that. Diagnostic test is blood test to see if the white blood cells are raised or platelet count is low. CRP test as indication for bacterial infection, and biopsy to rule out cellulitis. And the last one is psoriasis. The ruling in for this one is prominent border erythematous base with plaques. It has dry, cracked skin that may bleed and leave hemosiderin deposits. Factors risk including old age. Ruling out for this one is it has more thick plaques and has silvery white scales, commonly paired with thickened pitted nails. Typically affects knees, elbows, lower back. It may also affect eyes and joint as well. With psoriasis, you may experience burning or stinging sensation rather than an intense itch. Diagnostic test for this one is skin biopsy to rule out psoriasis. So therefore, I've come up with my provisional diagnosis as venous stasis eczema. I do notice that the case study does not provide a photograph of the thigh and upper arm. However, based on the photograph that is given, it is clear to me that there is a chronic venous insufficiency, which may be the underlying factor of the skin condition. Therefore, I would assume that the skin rash that the patient feels on the thigh and upper arms would have correlation to the venous insufficiency. Eczema is a skin condition that causes dry and itchy patch skin. So an eczema that is related to venous insufficiency is called venous eczema or varicose eczema. The clinical features of the venous eczema are consistent to the patient description and photograph that are shown, such as clinical features such as erythema that may appear purple or brown, hyperpigmentation, that pruritus, itchiness, which is the characteristic of eczema, asymmetrical border lesion, large areas of purpura in a liner shape, related to chronic venous insufficiency, such as hemosiderin deposits, lipodermatosclerosis, chronic edema, telangiectasia, and varicose veins, which we can definitely see on his foot and on his legs. Localized area and can be bilateral and mainly present on lower limbs, but can also affect areas with chronic edema, such as arms, which the patient mentioned that the itchy rash is on both his thigh and upper arms. In terms of based on the CEAP classification, the patient would have been a C4A and a C4B, which, if not treated, may lead to an open wound. So for management for venous eczema, the primary object of the treatment is to address the underlying venous insufficiency, reduce edema, inflammation or redness of the skin, itch, and skin overall integrity. So we can do compression therapy is a standard treatment that studies has shown has lowered the venous pressure on the skin. Patient will need to be advised to continuously evaluate the compression stocking though, for that elasticity and possibly to double the layer for a more effective result. Another one is exercise. So that would help get the fluid go running up again. Due to patient old age, simple exercises such as heel raise and stretching is recommended, as well as leg elevation. Non-soap cleanser, blend emollients and moisturizer can help reduce irritation and reduce skin dryness. As well as anti-inflammatory such as acetaminophen and metamizole, and topical such as prilocaine and lidocaine can help reduce symptoms. Laser therapy can also be an option to eliminate hyperpigmentation if that is a concern. And if conservative treatment does not improve the condition, patient can opt for a surgical intervention such as plebectomy and sclerotherapy to improve the underlying chronic venous insufficiency and prevent ulcer breakdown. And here are the reference lists. And that is the end of my presentation. Thank you for listening.